Hello and welcome to the fourth and final webinar focusing on intellectual disability and mental health. Thank you for being here tonight. My name's BJ Murray and we are hosting our webinar tonight focusing on intellectual disability and mental health. So I'm the Operations Manager for Coast and Country Primary Care, and we have partnered with the Central Coast Local Health District and the PHN to bring you a series of webinars that would build capacity on the Central Coast regarding intellectual disability and mental health. So I'd just like to start with an acknowledgement of country. We are proud to acknowledge the traditional owners of these lands and waters. We would like to pay respects to Aboriginal elders, past, present, and our emerging leaders. Our organisation is committed to work towards reconciliation. So if this is your first time here, welcome. We have done 3 other webinars focusing on intellectual disability and mental health. And if you would like to access those webinars, they are recorded. And they are on the PHN education website if you would like to access those to get a bit more information. But today we have Vince Ponzio from the Ministry of Health, and he is presenting on how strategy is translated to actions, outcomes, learnings, and the next steps for the intellectual disability and mental health portfolio. So then we will cross to Dr. Perry O'Shea, and she'll also be talking on how do we use evaluation to crystallise learning and evaluation of the IDMH programs, and what we have heard from people with lived experience and their needs, and how this shapes our lens moving forward. And hopefully we'll have some time for questions after that. And if you wanted to send a question through, just go into slido.com, www.slido.com, and the code is intellectual disability 3, and then you'll be able to put in questions throughout the presentation. There's also a small evaluation at slido.com, and we'd love your feedback if you've got time to fill that in. So let me just begin by introducing our presenters for the evening. Mr. Vince Ponzio is Director of Intellectual Disability Mental Health in the Mental Health Branch of New South Wales Ministry of Health. His role helps to provide statewide leadership and governance in the area of intellectual disability mental health, with a view to building the capacity of mental health services to better meet the needs of people with intellectual disability. Prior to his current appointment, he was Director of Mental Health Children and Young People at the Ministry of Health, and he's also worked with Justice Health and Forensic Mental Health Network with ageing, disability and home care. Vince has an interest in working with people with multiple and complex needs and in developing better and more collaborative service systems, and Vince's professional background is in clinical psychology. Also, we'd like to welcome Dr. Perry O'Shea, who'll be taking part in the presentation this evening, and she is a lived experience researcher who specialises in participatory qualitative research, working with people with mental health challenges, drawing on her lived experience as both a consumer and a carer, and her significant experience in consumer-led mental health policy reform, to action and facilitate co-designed and peer-led research and evaluation. Perry works for the Social Policy Centre at the University of New South Wales. So welcome to our presenters this evening, and I'm sure it's going to be really great information. So we're going to cross over to Vince now to start the presentation.
Good evening, everybody. It's lovely to be with you. I'd like to start by echoing the acknowledgement of the traditional owners of the land on which we're all meeting, and my respects to elders past and present. I'd also like to acknowledge people with a lived experience of intellectual disability and mental illness. Thank you to my hosts on the Central Coast, the LHD, and to Coast and Country PHN for the invitation to speak with you tonight. So without further ado, I'm going to go to our first slide. So I'm very passionate about the area of intellectual disability and mental health. I've worked a lot earlier in my career in disability and then moved into mental health. And it's been a great passion of mine to actually combine both intellectual disability and mental health perspectives. And my role at the Ministry is all about ensuring that mental health services work in a more responsive way to people with intellectual disability and their families. So just starting off with some of the key strategic focus areas. The first area is really about making information about mental health services much more accessible for people with intellectual disability and their families and carers. And I'll talk a bit more about each of these areas as we go on through the presentation. The next area is really about clarifying pathways and giving people options when people with intellectual disability are trying to gain access through mental health services, trying to give them a pathway and some options for care where previously they may not have existed, or there's been lots of barriers to people accessing care. The next areas are really around key partnerships, and those partnerships are with a broad range of stakeholders, and I'll talk a bit more about that. But obviously we need to work across our federal colleagues in the National Disability Insurance Scheme, as well as with a whole range of local partners, including GPs obviously, because they're a key player in this area. And the other thing I want to talk about is really the development of specialist services in the area of intellectual disability mental health. We certainly, a big part of what we want to do is to develop the mainstream capacity, and a really clear way of doing that is to develop specialist services to support the efforts of mainstream services to work with this group of people and to boost their confidence and skills in being able to meet those needs. Okay, so how do we turn that strategy and translate it into action? Well, we've got a number of easy read mental health resources that have been developed principally by our colleagues at 3DN, so Professor Julian Troller and his team at the Department of Developmental Disability Psychiatry at the University of New South Wales. And we've partnered very closely with them and developed a range of resources that look at access to the system, basic information about how to access services, information about conditions around intellectual disability, mental health, the Mental Health Act, and a whole range of other things. And I will, at the end of the presentation, I'll give you some links that will take you directly to those resources. Obviously, we're very keen to work with our partners, and Dr. Perry O'Shea will talk a bit about the evaluation around the residual functions just in a short while. But we're very keen on learning the lessons through evaluation, and we fund and are partners in research as well. This, as I say, a big part of our aim is to really improve the skills and confidence of mainstream mental health staff. We know from lots of studies and lots of experience that the confidence of people in mental health services isn't high when working with people with intellectual disability. Often they shy away from working with people with intellectual disability, and that's often because they haven't had a lot of experience. And this program is all about giving people some supported experience and skills in working with people with intellectual disability and their families. Now, that is really reliant on getting up-to-date education and lots of support and supervision. It's also about getting access to resources, not only for professionals but also for families and carers and people with disability. One of the things I want to talk about in particular today is the unfortunately named Intellectual Disability Mental Health NDIS Residual Functions Program. That is a real mouthful, but it's been an excellent program, and I know that a lot of the people who are involved in the program are online today, so I'd like to send my best to all of you and pay tribute to the excellent work that's been happening around that program. So the Residual Functions Program, I'll explain a bit more about that later on. The reason it's called Residual Functions is because it's supposed to bridge the service gap between the closure of New South Wales Disability Service, as the closure of ADAC, and the development or so-called maturation of the National Disability Insurance Scheme. So it's the capacity of the NDIS to really meet the needs of this group of people. Now, that was a temporarily funded program, and I'll talk more about the funding of that program in a moment. It doesn't look as though we're going to get recurrent funding for that program. And so we're going to have to look at other options, but there are other options that exist, and we'll be talking about those today. What the Residual Functions program has enabled is that within the LHD, within the local health districts that program exists, we've actually been able to identify key person or people who sort of fly the flag for intellectual disability and mental health. And they get involved in all sorts of things, whether it be direct clinical work or consultation, whether they help navigate the system for both families and professionals. They're resource people who really are problem solvers. And that's been a really key outcome, and we'll talk a bit more about that later on from the evaluation. It's all about, as I say, improving access to specialty advice and subspecialty advice, and it's about improving pathways and relationships with a whole range of services. But one I wanted to particularly call out was around the intellectual disability health teams, because the intellectual disability health initiatives and the intellectual disability mental health initiatives work hand in hand. It is a bit of a task to sort of sometimes differentiate them, and there is a bit of confusion out there in the sector still between what's offered from intellectual disability health, general health perspective, and what's offered from an intellectual disability mental health perspective. But they're important players in the market, and we need to bear that in mind. And the intellectual disability health teams and clinicians that are appointed to each of the local health districts are recurrently funded. So that's great news. That is great news. One of the areas that I want to talk about is the recurrently funded tertiary services, which are called the statewide intellectual disability mental health hubs. Again, hubs is a term that we've used. It's a term that's used by many services who talk about hub and spoke models. In our particular case, as I'll explain in sort of upcoming slides, we've got two services, one for adults and one for children and adolescents, who really provide specialist consultation to local services to enable really people with really complex needs to have another avenue of support, and for local services again to be boosted in terms of their capacity to see people by the provision of specialist advice. The adult hub offers a program called Project Echo, which is all about capacity building and training. It's an excellent program, and I'll provide some links to that program. And people are very much encouraged to investigate that as a way of building their own skills and capacity in this area. And the Sydney Children's Hospital Network, through their hub, their mental health intellectual disability hub, run a very successful kids webinar series with a whole range of clinical and related topics around intellectual disability mental health. And again, I'd strongly encourage people to follow those opportunities up. Next slide, he says to himself. Okay, so a bit more about the hubs. So the hubs are funded recurrently, and they're funded through mental health reform, and they're a New South Wales government commitment. So the service at Sydney Local Health District, as I say, works with adults and is called SIDMOS, so it's a statewide intellectual disability and mental health outreach service. The service for children and adolescents is based at Sydney Children's Hospital Network on the Westmead campus, and it's called the Mental Health Intellectual Disability Hub. And as I say, those services are very vital to the area of intellectual disability and mental health. They're recurrently funded, they're here to stay. They're reasonably new services, but they're a vital component of an overall approach to building capacity. And that's a big part of their work. So they get involved in clinical consultations, but they also take a very active role in training and building capacity. And I'll explain a bit more about what building capacity means in this context in upcoming slides. As I say, one of the big players in this area is the Department of Developmental Disability Neuropsychiatry at the University of New South Wales, headed up by Professor Julian Troller, who's very prolific in his research. Fantastic research team that has produced a lot of excellent evidence that has guided services in the right direction around working with people with intellectual disability in the mental health area. So a whole range, a whole suite of practical tools and resources, as I've explained, a whole lot of education and training options for professionals, for carers and families, for people with disability themselves, to get access to and to benefit from. So, coming back to the NDIS Residual Functions Program. So this was funded from 2018-19. Not all services started at that point, but some did. And the funding was for a 3-year period. So the funding is due to end at the end of June of this year. The funding initially came from the New South Wales Government. And as I say, it was at that point of transitioning from our statewide disability services to the NDIS, and the government really recognising that there were some significant gaps that needed to be addressed. And one such gap was around the capacity of mental health services to work with people with intellectual disability. Back in the day when ageing, disability and home care were very active and had a lot of funding behind them, they actually provided psychiatry and mental health services to clients through organised clinics, etc. And what we had was a real divergence of services. So disability services and mental health services in disability went in one direction, and mental health services really didn't have oversight over those services. So there wasn't great integration between what was happening in disability services and what was happening in mental health services. People who are as old as I am can remember a time when disability was within health, but that changed many, many years ago. And what we've had more recently is an attempt to really systematically look at building health and mental health capacity to work with intellectual disability in this area again, because that's been a neglected area. So the Residual Functions Program established, as I say, sort of time-limited programs in 10 local health districts and 2 specialty health networks. And they also funded a position each on the 6 specialist intellectual disability health teams in New South Wales. The programs were basically set up to respond to local needs, but they had some shared aims, and they included increasing access to mental health services for people with disability, and, as I say, improving skills, capacity and confidence of mainstream mental health staff to work with people with disability and with co-occurring mental health problems. Now, each program was led by the local health district or the specialty health network, and it targeted local needs. So it targeted the specific mental health needs as they were understood by the local health districts, by the local population and demographics, and it really looked at targeting the capacity, skills and experiences of people in mainstream services, many of whom had not had much exposure to working with people with disability, and who in some cases had actively shied away from that opportunity. So each of the 12 programs had a clinical focus and or a capacity building focus, and usually both. Okay, so they got involved in direct clinical services, but they also were a conduit and like a resource for mainstream services to build up their skills and capacity. I've gone too far. Okay. All right. I think we're back on track now. Sorry about that. Okay, so a bit more about capacity building. So in this context, we're talking about capacity building as a way of building skills and confidence, of providing access to increased training and support, of really giving people more skills in connecting with families and carers of people with disability. And that includes the whole range of connection, whether that be around direct clinical care or in planning and evaluation of services involving carers and people with disability at all phases of that process. So we're looking at improving the range of evidence-based therapies, whether that be through the results of evaluations or research or other means. We're looking at embedding those resources to support ongoing care across mental health services. So we're really trying to establish sustainable solutions for people and sustainable capacity. We're looking at developing pathways and relationships, links with a whole range of services. And I've listed some of those there: the local health districts, NDIS providers, primary health networks, GPs, private providers, disability services, to name quite a few. And we've got a number of resources there that I will also talk a bit more about. There's some of the educational resources that are available in the area of intellectual disability and mental health. Back. Okay. So these are some of the services. So just taking our host LHD tonight, Central Coast. So Central Coast was slightly unusual. Together with the Sydney Trons Hospital Network, Central Coast and SCHN focused more on young children under the age of 12 in Central Coast's example. Most of the other services focused on the needs of adults, but in Central Coast the focus was on disability navigation, on behavioural assessment and capacity building. There was some fantastic work done around paediatric behavioural triage clinic model and looking at the increasing capacity for assessment for children presenting with a whole range of behavioural problems. You can see there that we've got 12 of the programs listed with a range of capacity building, direct clinical services, consultation and liaison services, all represented there. And I mean, this is one of the issues of working with a statewide approach. So basically we want to get a blend of locally driven solutions with some consistency that's provided at the central level. And getting that the right blend is the sort of $64 question. And one that we're still learning about in terms of the residual functions program. But it's been a very rich source of information. We've learned a lot from this program. And again, my thanks to all those people who've worked so tirelessly in working with those services and achieving such great outcomes. Some of the LHDs that are listed there were areas in which there'd previously been clinics operated by ageing, disability and home care. So they are areas like Western New South Wales, Murrumbidgee, and also I think the Hunter was also an area in which there were lots of intellectual disability services operating. A lot of the larger residential services for people with disability were also based in the Hunter, so that's been a rich source of information there. Okay. I'm having a bit of problem with my little flicker here. So this is around, so some of the lessons that we've learned around common links. So these are the common links that distinguished the residual functions program. So each service included both clinical and capacity building elements, so both vitally important. Most services targeted adult care, as I say, with 2 services focusing on the needs of children and young people. Most services accessed and promoted existing education resources and then developed their own, in many cases, that were locally driven and responded to local needs. So some of those sort of pre-existing education resources included the core competency framework and the guide for accessible mental health services, and as I say, the intellectual disability and mental health e-learning modules that were provided through 3DN. So one of the things that really marked the program was the strong relationship that was developed between the leads in the local health districts and the networks and NDIS providers. And this support was really vital to providing wraparound support for people with complex needs and really establishing pathways for people with complex needs in their families. And families have been very vocal in extolling the virtues of this program. And one of the ideas is that one of the issues that comes out very strongly is the fact that they were trying to navigate a system. They didn't know which door to access, and having a resource person who knew about intellectual disability and mental health, knew about the service system, knew about the network of providers from the NDIS, etc., knew the local services, it just added just very significantly to their whole experience of care. And collaboration was a key part of the program, and it was a very active and well-connected network of IDMH leads across the local health districts and the specialty networks, and they did particularly well at getting together, sharing ideas, resources, projects, challenges, and that worked particularly well. Now, we'll get an opportunity to talk more about some of these issues as we go on, and obviously we'd welcome your questions. We're going to go to Perry now, so I'm just going to give her just a minute or two to get herself ready, but we'll go to Perry for her slides.
Hi everybody, I'm Perry. I'd also like to acknowledge the traditional owners of the lands on which we meet today. I'm down South Sydney in Dharawal country, and I'm not sure how many of you where all you're meeting, but also in light of what we do, I'd like to acknowledge people with lived experience of mental illness and those in love and care for us, and people with lived experience of intellectual disability or other cognitive challenges. Thank you also to Central Coast LHD and to Coast and Country PHN for the opportunity to speak today. So before I get started, I'll just say a little bit about me that isn't so much in the bio, and that is that I have a lived experience of mental illness, and I also have a lived experience as a carer of children with cognitive challenges. I do quite a bit of work for the Social Policy Research Centre on the different mental health evaluations. My words went all foggy in for a minute. The work that we're doing in the intellectual disability and mental health spaces is really close to my own heart, I guess. So and particularly interesting from that point of view. So I'm going to talk a little bit about the evaluation and the role of evaluation, and also talk about the co-design of that evaluation. So the Social Policy Research Centre at the University of New South Wales, is conducting evaluations on behalf of the Ministry in both the Residual Functions Program and the Intellectual Mental Health Hubs, both of which Vince has talked about. And so the Residual Functions Program, as Vince has mentioned, it was a time-limited program and it will be ending very shortly. And that evaluation is almost complete. The hubs evaluation, we've started already almost from the beginning of the program, and we'll be doing that for until the end of 2023. So we'll have a lot of opportunity to do some longitudinal work in the hubs evaluation. So evaluations, I'm involved in quite a lot of different evaluations over a period of time. New South Wales health program evaluations and others. So things like HASI Plus, and also the Pathways Community Living. And the evaluations actually provide really valuable information about what's working and what could have improved. Also, evaluations provide important evidence about the effectiveness and worth of programs. So the evaluations for the intellectual disability programs include a value for money component, which is really, really important. And of course, they include a lot of work around the quantitative data, minimum data sets for the hubs that is being tested at the moment, the minimum data set, I believe. But my main involvement in the evaluations is around the design of the evaluation, but also in the qualitative research, collection and analysis side of things. Can maybe the person that's writing on the thing can just let me know if can be heard. Every now and again, my slides go a bit blurry, so I don't know if my eyesight's going or the slides are going blurry. And another important thing about these evaluations, okay, excellent, thank you, is that they're formative, which, there wasn't a lot of formative work we could do during the residual functions evaluation because it wasn't very long, but definitely in the hubs one, there'll be opportunity during that 3 years for us to provide feedback, and that feedback to be fed back out to the field. So things can be changed along the way, which is really important. It's not just about getting a report at the end. So, we're already on the next slide. That's great. Another really important feature of the evaluations that we do at the Social Policy Research Centre, and that I head up a team of lived experience researchers, and we train and support people who have lived experience of mental illness and intellectual disability to be involved in the research. So this ensures that all voices are heard, and what often happens in evaluations or research is the marginalised voices are the hardest to hear. So we actually we work with people that have that lived experience, so that those voices can be heard, and those people it's easier to engage with those people. So also these evaluations have been co-designed. So there's the lived experience researchers that work with me actually are involved in the design processes, or the research methodology and all the tools we use. But we also have lived experience people on the research advisory committees as well, which managed and supported through the ministry. So the lived experience researchers, or people with lived experience, contribute in these evaluations to design the research process, participating in the data collection. So they come out and do interviews, or in the last year, also a lot of focus groups over this type of forum, Zoom or Skype forums, and also help with the analysis and reviewing and providing advice on reports. So I found that the lived experience researchers really contribute to much more relevant research processes, so that they, especially in the intellectual disability space, I found that the people on our team that have a lived experience of an intellectual disability really pick us up, and it made me rethink. Every time I write an email now to whoever it might be, I think about how I'm writing it and how many full stops I put in it and how clear I might be being. So really make us think about clarity, so that people actually have access to information, the size of information, the way we present things, how we approach people. It makes the whole process much more relevant. And anybody that's had the privilege of being interviewed by one of our researchers and has been actually pulled up on something they said, or you know, the way the room was designed or something, has actually you know, been in a situation where they might be first of all just take it a little bit back and then think, oh, they'd never really thought about it from that perspective before. And we get a lot of feedback in terms of how that ended up being really valuable advice that they received. In lived experience researchers also really increase our engagement of consumer and carers, make people feel safe, and really engender that trust and that relationship building. So they're just invaluable from that point of view. And they enhance our learning opportunities, as I've already said, just by giving us a different perspective about how to look at things. As I said at the beginning, I'm a person that has a lived experience of mental health challenges. I have a mental health diagnosis. I also have grandchildren that I foster, that one's got a moderate intellectual disability, the other one's got an autism spectrum disorder. But actually working with people that identify themselves as having an intellectual disability has changed how I think about things, even how I relate to my own children. So it does enhance our learning opportunities both in the research and beyond. And it definitely, because they also are involved in the analysis and what this really means, and in reviewing and providing advice on reports, and also drafting parts of reports, the end results end up being more meaningful as well. Next slide, please. So I'm going to talk a little bit more about the results of the Residual Functions Program evaluation, particularly what consumers and carers told us. Of course, we spoke to key stakeholders and service providers and the project teams. And so the report on the Residual Functions Program, the evaluation report, it also includes quantitative information, as much more comprehensive than what I'm going to focus on in this presentation. But I want to talk in particular about what consumers and carers told us in this evaluation. So consumers and carers told us that they really liked and they really have experienced an improved access to mental health services through this evaluation program. In fact, for quite a few consumers and carers, it was their first access to mental health services, and particularly psychiatric services. Some people did have some access to psychiatric services through ADAC, but they found that the ones that they were getting through the Residual Functions Program were actually much more comprehensive and reliable and much more suitable for their situation than they'd had previously. Many people hadn't had any access to any mental health services at all. And people also told us that the services they were offered through the program were relevant and welcoming to people with intellectual disability. So the sorts of things that they found was they weren't confronted to a waiting room full of people. That things were well structured so that they didn't have to wait around if there was, something didn't go quite right in terms of timing. There was somewhere else where they could go to wait. They also found that having people that they knew to welcome them, to have the same support staff around the clinical staff was really helpful. Going into settings that weren't overly hospital or institutionalised, they found really helpful. They also found that if they went to a regular mental health service, that they noted that there was changes in how they were treated as a person with an intellectual disability. So that capacity building was beginning to come through in the Residual Functions Program, with much more access to services, and also with the services that people are already accessing improving. Really important, I think this is what Vince spoke about when he talked about the partnership between the NDIS providers and the the Residual Functions program team and the clinical support was that there had been a quite significant improvement in support within residential settings for people that have an intellectual disability and a mental illness or mental health challenges. And some of that support was really hands-on, with clinical staff going to residential settings and training people within those residential settings, frontline workers, on how they might be able to better manage the behaviours that they were experiencing in those settings. And consumers and carers and frontline service providers gave us a number of examples like that, and where things had improved quite significantly, with people, with consumers in particular, needing improving their outlook on life, and their well-being had improved, and their medications have often, in many cases, been quite significantly changed and reduced, so that they were much more with it and alert. Also, consumers and carers talked about improved relationships within families, and it's not an exaggeration to say that the Residual Functions program in the short time that it operated actually changed lives. And if we've got time, I'm just going to read a couple of stories that we've got in the end of the report. Now, these stories are not anybody's names, and they're not even one person's story, so they're a bit of a composite of a number of consumer stories, consumer and carer stories. So the first one I'll tell you about is Sally. So Sally wants to find paid work. When Sally was a young girl, she was abused and neglected. Until recently, Sally lived in a house where she often felt scared of the people she lived with. When Sally moved into her current home, she did not trust her new support workers and housemates. At first, she stayed in her room and did not communicate with them very much. When Sally started on the program, the doctor listened to Sally's story, acknowledged her trauma, and helped her understand how her childhood experience had affected her behaviour. The doctor also gave her different medication. Sally then found it easy to talk with others in her home, and now she loves to spend time with her housemates. Sally then worked with support workers to extend her social circle, first to the daycare centre and then to paid employment. And that is a composite of true stories. In fact, I can remember, I can hear the stories in my head as I'm reading it out. I'll just, if you indulge me, I'll read one more. Jim likes to spend time in the bush with his grandfather on weekends. Jim lives in supported accommodation with 3 other people and a support worker. He communicates without speech. Sometimes Jim gets upset and he shouts at the people he lives with or with the support worker, or to the support worker, sorry. Jim had to take lots of medication, which made him sleepy and feeling a bit sick. Sometimes Jim felt even too tired and sick to go into the bush with his grandfather. Since joining the program, the support workers at Jim's home are doing some training about intellectual disability and mental health. So it's that capacity building we're talking about. They're also working with Jim and his mental health team to come up with ways to help Jim when he gets upset. Jim now takes less medication and is not so sleepy. Last weekend, Jim and his grandfather went fishing, and Jim is really looking forward to sharing the photos of his catch with his housemates. And there's other stories like that at the end of the report, including quite a long one about a carer story and that improvement in the relationship within the families. But not all was rosy. That there is some suggestions for further change. And one of those was continue to make the mainstream mental health services more relevant and welcoming for people with intellectual disability, and that's why the intellectual disability mental health hubs are so important. That capacity building side of that. I think what the Residual Functions program did show is that importance of having that specialty service. That in the long run, people do want better services, more relevant services, people with intellectual disability within mainstream mental health services. And of course, there was concerns from consumers and carers and service providers and key stakeholders around the short-term nature of the Residual Functions program, but especially around the concerns of losing access to a specialised psychiatrist in some areas where they can be very hard to to get hold of. And I think that's all I'm going to tell you, but I'll stick around for some questions. Thank you. Thank you for your time.
Thank you, Perry. We'll get to some questions just after a couple more slides, and I'll certainly be throwing to you with some questions as well, Perry. So just in terms of lessons learned, cool, questions coming in, fantastic. Okay, so it's just in terms of lessons learned. So statewide coordination did mean the program saw themselves as part of a bigger system, as we were saying, part of a network. They were more engaged in supporting one another across boundaries, and they really benefited a lot from that, and services and consumers and their families benefited from that experience very much so. As I was saying, we do need more consistency in the activities of each local health districts and a bit more centralised direction to blend with that local experience and local responsiveness to needs. And that will be a part of where we're going, and I'll go to our directions in intellectual disability and mental health to the next slide. One of the lessons learned was that despite the positive changes, we still need to work really hard at making mainstream services more welcoming, respectful and inclusive and accessible by people with intellectual and developmental disability. So some really important gains have been made. Residual functions have been very much a part of that. The hubs are now part of that, and other initiatives, including 3DN and lots of other things that are happening. But we still have much more work to do in terms of getting that right blend of mainstream capacity and specialist capacity. One of the areas that comes up time and again is around data. So our data systems don't really capture people adequately who have intellectual and developmental disability. And we're really playing catch up around that. So we've engaged with our partners at Inform, which look at all our clinical data collections. And we're looking at working much more closely with them about collecting and really identifying people with disability in the system and looking at their patterns of service use and how we can really learn from that and develop services that better reflect the needs that are there through good, hard data. So obviously local services having access to data is very important to their planning at a local level. And again, through our partnerships with Inform, through our partnerships with 3DN, we are looking at giving those local services much better access to data, to real-time data. And one of the problems, as people are aware, is the huge lag often between when we ask for data and and the sort of the contemporaneous nature of it. So it can often be months out of date by the time we get it. So we need to look at systems. We've looked at, the area of suicide monitoring. We're getting much better data now, and we're certainly looking at intellectual disability and mental health and how we can improve getting more timely data in this area. One of the big issues that we've heard from families and so on is that we really didn't know much about this service. So it's really important that we promote the initiatives that we're undertaking in intellectual disability and mental health, including the residual functions, including the hubs, and everything else that we're doing in this area. And we've got to look at ways of getting that message out to clients and their families, to professionals, to the sector at large. Okay. Our last slide is about the future of intellectual disability and mental health in New South Wales. So we are committed to the continued implementation of the statewide hubs. They are recurrently funded. In the regrettable absence of the residual functions program, we are committed to the ongoing development of a statewide intellectual disability and mental health network. We really want to sort of preserve what we can from the lessons that we've learned from the residual functions program, and develop some expertise that sits in each of the local health districts and specialty networks to really look at clinical and capacity building in the area of intellectual disability and mental health. And we're looking at ways that we can do that through other sources of funding, but ensuring that in each local health district in New South Wales, we have expertise that we can bring to bear in the area of intellectual disability and mental health. That means working with inpatient teams, it means working with community mental health teams to continue to build their confidence and skills, their exposure to this area, their exposure to working with people with intellectual disability, their exposure to training and supervision, and lots of support. We want to look at whole of government coordination through systems where people with cognitive impairment are overrepresented. Now, one of the obvious areas that we are working in is in the area of criminal justice, where people with intellectual disability and cognitive impairment are very much overrepresented in the custodial population and the population that have contact with the criminal justice system. Part of the work that we're doing is looking at some of the legislative reforms in the mental health legislation, so in the Mental Health Forensic Provisions Act. It's looking at developing pathways for people with cognitive impairment. It's looking at really specifically recognising that someone can be not criminally responsible because they have a cognitive impairment that's impacted on their judgment and their capacity. So we are working with colleagues at Department of Communities and Justice and with a whole range of government partners to look at the needs of people who come into contact with the criminal justice system for forensic patients under the Mental Health and Forensic Provisions Act, through what's now been introduced as the Mental Health and Cognitive Impairment Forensic Provisions Act. Another mouthful. Okay. We also want to facilitate pathway development between existing and new service providers. Obviously, we're focusing on the National Disability Insurance Scheme. We've got a long way to go in ensuring that those pathways sort of address the many barriers that are in people's path. But we're committed to doing that. And we're committed to ensuring that there is, where possible, better communication between state services and federally funded services, and that is a huge challenge. But it's one that's being faced by services in many different ways, whether it be through people presenting to community mental health services, or people presenting to emergency departments, people being admitted to inpatient units who then, who don't have a pathway beyond that unit because of the lack of support services that are set up for them in the community. So getting access to well-funded, appropriate NDIS packages is a huge part of the work that we want to do. We want to address the many barriers that limit access to mental health care for people with intellectual disability. We've talked a lot about that. So programs like the Residual Functions program, the evaluations that are happening, are all pointing us in the direction of barriers that people experience. People really want much better access. And I know that's certainly a theme that's coming out strongly in some of the questions that I've seen so far. So we can try and address that as we go on. Importantly, when we want to consolidate the positive changes and enhancements that have been made, and we want to continue to build the system's capacity and responsiveness to work with people with intellectual disability. Okay. That is it for the formal presentation. Thank you very much for your attention. And I will go straight to questions. Okay, now I'm going to read the questions and then attempt to answer them, or throw to Perry. So the first question is, how do the hubs work with the residual functions clinicians and mental health staff? So essentially the hubs are a small specialist team who work with complex presentations. So they do not manage people in an ongoing sense. So they would see people in a time-limited way, but they rely on local services to manage people in an ongoing fashion. Now, in LHCs where there's a residual functions clinician, that's often the pathway that it would go through. So it would go through the general mental health service, through the residual functions specialist ID mental health clinician, onto the hubs, and then back again, sort of looping back, with some recommendations for care, for recommendations for better practice for that individual. In those LHCs where there's no residual functions program, again, referrals would come from the mental health services. They would go up to the hubs and they would come back to the generalist mental health services. As I say, the challenge is about developing expertise that we can call on in each local health district. I've just been handed the Dorothy Dixer, which is why is the residual functions program not being funded? I'll get to that very soon. But it's obviously the elephant in the room that we need to directly address as well. So that's how the hubs work with the residual functions program and the mental health staff. So the idea is that, as I say, that the local services be responsible for the ongoing care of that individual, for their case management, if you like, in terms of from a mental health perspective. But the hubs provide very specialist, targeted recommendations about how care can be improved. And then there's ongoing capacity building and interaction between the hubs and the local services in terms of the needs of that individual and their family. Let's get straight to that question about funding, and I'll do my best to answer that, and then we'll go on to the other questions. So why is the residual functions program not being funded? It's a very fair question. We certainly approached various tiers of government, both New South Wales and federal government, in terms of getting the residual functions program recurrently funded. But at this late stage, we haven't received any positive news, and we must assume that recurrent funding won't be forthcoming. So to some extent, the residual functions program has been caught up in some of those issues between state and federal governments. From a state government perspective, disability services funding in this state was given over to the National Disability Insurance Scheme. And so the state's expectation is that the federal government will have a more active role in working with people with disability and providing for their needs. From a federal government's perspective, the federal government accepts responsibility via the NDIS for the disability support needs of individuals, but the health and mental health needs they see as a state responsibility. The state, given the multiple demands on the state's health budget at the moment, I don't need to remind anybody about what those demands are, but intellectual disability and mental health is an important area, but it's not one that has met that level of priority. And it has been a bit of a subject, it has been a bit of a victim of sort of territorial discussions and debate between state and federal governments. From a mental health branch point of view, we want to do our utmost to try and promote intellectual disability and mental health. The residual functions program was very important because there was a real recognition that there were significant gaps in this area, and there are still significant gaps that we must address. But we're going to have to find other ways of doing that. We're going to have to develop networks and other sources of attract other sources of funding apart from the residual functions program. We'll have to learn what we can from the residual functions program, but look at other ways. But we're absolutely committed to doing that and to keeping what momentum we can around boosting the capacity of mental health services to work with people with intellectual disability. Some really important gains have been made through residual functions, and we're intent on ensuring that is capitalised on. So I'm not sure if that's the answer that people want, but it's the most honest answer I can give around funding. At different points in the cycle, I've been more optimistic about getting funding, but as I say, at this late stage, it would be irresponsible for me to lead people to believe that the program's going to be recurrently funded. We've just got no clear indication that that's the case. Okay, trying to maintain positive momentum now. The next question is around evaluation. So did the evaluation tell whether people with intellectual disability were able to more easily access mental health services? Well, it did, and I'll also ask Perry to add to my answer, but the evaluation absolutely did say that people were able to access mental health services. You know, it's not surprising because we've actually funded specialist intellectual disability and mental health services in many of the local health districts. And so people were able to take advantage of that. And as Perry said, for some people, for the very first time, gain access to mental health staff, to gain access to specialist psychiatrists, etc. in this area. It has the residual functions program and the sort of the funding of specialist clinicians and workers in intellectual disability and health has also had a very positive impact on the culture of the mental health services more generally. But you know that's the area in which we need to focus. We need to get that blend right between specialist and mainstream, and we know that that there is stigma within mental health services around working with people with intellectual disability. We want to address that squarely, and we want to do that in a number of ways, and we want to call that out, and we want to, as I say, correct that and support better practice. So there is some positive news around the evaluation. Perry, would you like to add to that answer?
Yes, I would. Hi, everybody. I'm actually going to add to that answer and then circle back to the other two questions because I have something to say about those as well. So yes, the Residual Functions program did increase people's access to mental health services. Well, firstly, there was a specialised mental health service set up for people that had an intellectual disability or other cognitive challenges. So they, like I said before, they often had access to mental health services for the first time. And also there was the beginning of a culture change within mainstream mental health services. So what there is, so thinking of the Residual Functions program and then it was a time limited program. What it did do though was it really raised awareness of this issue. It raised awareness within mental health services of people that have an intellectual disability and the complexities around having an intellectual disability or cognitive challenges and mental health challenges. And it also raised awareness within the NDIS and other disability support services around the importance of actually properly managing people's mental health challenges. And an increasing exposure in both those areas. So increased exposure for people that worked with people with intellectual disability around the idea of mental health and increased exposure quite a bit for people that might not have worked with people that have intellectual disability or other cognitive challenges within mental health services. But that really brings me back to the first question that was asked, how Vince described how the hubs work with the residual function clinicians and mental health staff is ideally how they should work, but even with a little bit of work we've done so far on the hubs, there is still lots of problems in terms of people with intellectual disability actually accessing mental health services in the first place. So particularly in the child and adolescent area, most of the referrals don't come through mental health services, and it can be really hard to get mental health services to be involved in even after the hubs has been involved, because there still is that need for more exposure and more capacity building and awareness around the complexities. So people still think about health services as being for the most mentally ill, or the most people that are the most unwell in a mental health sense. So not realising that complexity of having cognitive challenges and mental illness means that people might need access to health services, even if they might not, that the complexity is important, not just the mental illness itself. I think that's all I wanted to say about that. But I may have just generated some more questions with my roundabout answer.
Thanks, Perry. I'll just go on with a few more questions, and I'll throw to you as well and make sure that I give you an opportunity to add to the answers that I give. I'll just duck over here. So this question is about what's the first resource you'd suggest someone who's interested in working in intellectual disability and mental health access? Look, there's probably not one particular resource, but I would definitely encourage people to look at, and I'll give people the slide, the link to the ID mental health resources, the 3DN page, because that's got the e-learning resources are fantastic in terms of their breadth, and they're written for a whole range of audiences, whether the person is a carer or an individual with disability, or a family member or a mental health professional, or a health professional more generally. They provide a whole range of resources, and it's a really useful introduction to the area of mental health, the complex interplay of mental illness and intellectual disability. It's a really fascinating suite of resources, so I would strongly encourage you to do that. We're going to make these slides available. I've just remembered we didn't actually get to the final slides where I've given people links, but we'll send these slides out to people, won't we? Yes. Okay. Perry, did you want to take that question? Are you happy to take that question around, what's the resources that you would point to for people who's interested in working in intellectual disability? Where would you direct them?
Okay, I also would direct them to 3DN, also the Council of Intellectual Disability, and also you can learn a lot just by talking to people that have an intellectual disability and their carers. So, you can make those connections through the Council of Intellectual Disability as well.
Perry? Yeah, no, that's good. That's good. I mean, I think they're 3DN and the Council for Intellectual Disability are certainly two of the more highly regarded sources of information. So, Perry, while I've still got you there, I want to the next question is about the carer experience. So, as a carer, I find it very difficult to get a clear picture of the services that are available for my person with a disability. What would be the first point of contact for carers, do you think?
Probably I'd go to the Council of Intellectual Disability as well. But if you've got a person as a carer, if you've got a person who has an intellectual and a disability and a mental health challenge, also would be looking at trying to access mental health services. And I guess the first point of access for anybody that has a mental health challenge is your GP. So if you've got a good GP, you can make those connections. That's also really helpful. I'm just thinking also because I'm a carer of children that have intellectual disability. One's got an intellectual disability, and they both go to special schools. So that's also, they've been extremely helpful in making connections to other services, the schools that they go to. So if you're fortunate enough to have that, that's helpful as well.
Certainly agree. Going to your GP is always a good idea, and they're a great source of information, and they know the local services. In terms of mental health carers, there's a Mental Health Carers Association that is also, particularly good at linking people up with services and giving advice. And they also sit on our intellectual disability advisory group, so they're becoming more aware of the particular needs of people with intellectual disability when it comes to mental health services. So thanks for that, Perry. Perry, this is another one for you. how has working with people with lived experience of intellectual disability been different to other evaluations that you've worked on?
It's been different in that we're being much more, I guess, focused or aware of how we present things, how we talk about things. It's made me much. I've been training people on how to work with consumers and carers for many years, and I talk about access to information and how to make information more accessible. But it wasn't until I worked with a team of people that have intellectual disability or are on the autistic disorder spectrum that I realised that I wasn't quite there myself. So it does make you really mindful, much more mindful of how you present things. But it's also been like an absolute. It's been extremely interesting and a joy, really, to work with people, and also it reminds you. It's sort of like, practicing what I preach, but it reminds you that everybody has something really valuable to add to an evaluation or to any exercise, I guess, and that capacity comes in all shapes and forms. So, and capabilities and competencies as well. We're talking about people that are really, really good at what they do with the right support and training, and have really added a lot of value to the project. So, and as I said in my presentation, it's changed in some ways how I relate to my own grandchildren who I foster, because it's just made me sort of rethink about things from from somebody else's personal experience, personal point of view. So, yeah, hopefully that answered the question.
Sorry. I'll take the next one, which is around are intellectual disability mental health teams in each LHD affected by the ending of the funding, or are they technically the hubs for each LHD? Okay, so we talk about the hubs. Everyone talks about hubs, but in intellectual disability mental health, the hubs are the two statewide services. Okay, so we know that the Residual Functions program, it funded programs in 12 of the 18 local health districts. What we want to ensure is that there's representation, specialist representation in intellectual disability mental health in each of the local health districts. But there's no doubt that the funding that we will have available, it won't be to the level that we had under Residual Functions. So there'll definitely be a reduction in funding, but we're going to have to try and be as strategic as possible in deploying the resources that we have available to us. So we're going to have to work and negotiate with each of the local health districts. So with the Residual Functions, many of the LHDs were able to provide excellent services. Some of the LHDs didn't provide specialist services for intellectual disability or provided very few. So our intention is to even the playing field up a bit by providing specialist services in each of the local health districts. But there's no getting around the fact that the overall funding envelope has been reduced. So we're going to have to fall back, go to plan B, but still be very positive and optimistic about what we can achieve, because Residual Functions and the other initiatives that are in place, whether it be the hubs, the work through 3D and etc., it's all coming together as a combined effort, and we're going to learn a lot about those, about how we can promote better practice in intellectual disability and mental health by all those things. So whilst I don't want to be a Pollyanna and talk about the fact that the the funding won't matter. It will matter, but we also have some contingency plans, and we're absolutely determined that the future will involve better services for people with intellectual disability through as many means as we can gather. Are there any opportunities to apply for funding for specialist inpatient wards? Look, there are. I mean, there's lots of needs in intellectual disability and mental health. We've focused more on the community-based services, but also we need to look at the mainstream inpatient services and people's experiences in hospitals and emergency departments. We certainly the overseas experience has been that there's some value in developing some specialist services, inpatient services for people with intellectual disability or people with autism spectrum disorder. In Australia, there's a unit in Victoria that's specialised in seeing children with autism spectrum disorder and working with kids who have quite complex behavioural presentations, working with them and working with their families. And that's one of the things that we want to learn from. We want to learn from the experience that our colleagues have had in Victoria, and we are looking at that model. At the moment, there's no clear-cut plans to have specialist inpatient services, but it's certainly part of the matrix of services that we need. We've got some more fundamental challenges that we're dealing with at the moment, but in the future, I think we'll definitely be looking at specialist inpatient facilities. But as I say, our aims at the moment are more modest and more basic and more down to earth in terms of the sort of the day-to-day practicalities. Okay. Okay, Perry, go ahead.
I just want to say something about the specialist services, because that's come up in the focus groups for the hubs, and someone said, "Be careful what you wish for." But from a carer's point of view, as with a teenager who's autistic and also has post-traumatic stress disorder and quite high anxiety, which goes with the autism. He's just had an accident last year, and we spent 3 months in Westmead, and he needed his own room. And the few times when things got a little bit crowded and he didn't get his own room, they moved him out pretty quickly back into his own room. It's best, I think, if we can keep people in the community, but if they do need to be in hospital, they probably do need specialist services, particularly on the autism spectrum disorder.
Thank you, Perry. Perry, whilst I've got you, this is a question about what stood out for you as unique to residual functions from your work with evaluating the program.
I think that really strong connection between health and NDIS, much stronger connection than we've seen in other programs. Like HASI and like the housing programs, or even the Pathways Community Living Initiative program, which uses NDIS quite a lot to house people. The Residual Functions program managed to make a really good link between mental health support and to the frontline workers within the NDIS support agencies, which I haven't seen before in other programs. And in fact, it's always been an issue. Like in some programs, it's like the HASI and the HASI Plus has been seen as like really good programs, and they are really good programs because they keep that strong connection because it's a New South Wales Health program, they keep that connection with the clinical support and the community mental health, whereas it's been seen as once people go into the NDIS world, they lose that connection, and there is that connection. But this Residual Functions program managed to forge that connection and really make it work. As those stories that I read, they were about that connection between the NDIS and the clinical support. I think that's the biggest thing.
Thank you, Perry. I'll take the next one, which is around what scope could there be in the future to have specialist care to support people with intellectual disability in non-traditional settings? So we've talked today very much about traditional settings in mental health. We've talked about community-based mental health services, inpatient services, presentations to hospital, etc. I think this really gets at the heart of what Perry was just saying about our relationship and connections with the NDIS. I think there's a long way for us to go, and the residual functions have led the way in terms of engaging with the National Disability Insurance Scheme and with the providers that are funded by that scheme, in terms of a better relationship and a more integration between what the specialist mental health system offers and what the NDIS and that sort of service sector can offer. So I can see that there are opportunities there for much more non-traditional settings and for more supported settings, more disability friendly settings, if you like, that sort of blend mental health expertise with disability expertise. But it really is contingent on us developing further with our relationship with the NDIS and really understanding more about how the state health system can provide services around health and mental health, and how the NDIS can provide wraparound care for people. But it's very hard. See, part of the argument is that we get into semantics about what people's primary problems are and so on. So the NDIS was about not getting into those arguments. It was about seeing the person as a whole and then responding to that person's whole needs, whether some of them whether they were specialist mental health needs or health needs or other needs. You saw that person as a holistic individual. So it hasn't worked out that way in practice. So the NDIS has been very, I don't want to get too political, but I don't think I'm letting the cat out of the bag by saying that the NDIS has been very particular about who they will support and the circumstances in which they'll provide that support. So it's really a challenge for all services to work more closely with the NDIS and to really reach a point of agreement that is in the best interests of the clients that we share. Perry, did you want to take that up?
No, I agree with everything you've said. Only that I guess that when we're looking at mental health services too, we're hoping that they look at the whole of the person in a recovery-oriented, trauma-informed way, the whole of the person's life. But it is difficult because it's in a health setting where that's not something that's normally done. And also in the residual functions program, consumers and carers, I think in one area there was almost by accident that they ended up in a community setting to see their psychiatrist rather than in a health setting, and they found that was something that they really liked. Sometimes the health settings can be a little bit daunting for people with intellectual disability, especially if they have other cognitive challenges as well.
And that's where carers and families really talk to us about the importance of having key contacts who they can talk to in terms of being a bit of a navigator. And we know that particularly in inpatient mental health services, they're not particularly good at communicating with people with disability. And having someone who actually understands people with disability, who has the capacity to communicate and be that sort of go-between means a lot to families when their loved one is in dire straits. I think we've got time for one more question, and the question I have here is around what can be done to shorten the waiting lists for specialist services. That's a very good question. Look, I think obviously one of the areas is equitable investment, okay, across the board, and trying to look at the needs across the state and try and provide some level of consistency. But a lot of it's about wise investment, and a lot of it is about people recognising that they need to be flexible in the services that they offer. So it's about a whole range of things, and when we talk about capacity building, it is about the systems that services put in place to triage people, to determine when they will be seen, who they'll be seen by, where they're seen, and to do that in a timely way. So in a way, it's an extension of capacity building for services to be more inclusive and more responsive to families. But in the end, it is very much driven by resources, and so we shouldn't shy away from that. It is about ensuring that we have a level of investment that sustains a service's capacity to see someone in a timely way. Perry, did you want to add to that?
I just maybe thought we should be careful what we wish for or what we set as benchmarks. I'm not sure that we want to necessarily just shorten the waiting list. One way of shortening the waiting list for mental health services overall has been to deny access to certain groups, including people on the autistic spectrum and people with intellectual disability. I guess it's more about like how can we make sure that people get the support that they need, clinical and otherwise.
I couldn't agree with you more. I mean, that's a really important point, because we don't want services. I mean, you mentioned some of the CAM services. We don't want services to set up a whole range of exclusion criteria. We want people to be included and prioritised on the basis of clinical need, and in a way that doesn't discriminate on the basis of someone having a disability. So it is really about equity, and about services understanding what their role and responsibilities are to this population. I think that's it for us. Now, as I say, before I hand back to BJ, I'd just like to say that the slides will be made available to everybody. They include at the end a whole range of links to services and resources, including the hubs, including 3DN, Council for Intellectual Disability, and other resources and sites. So I'd encourage everybody to have a look at that. Thank you very much.
Great, thank you. Thank you so much, Vince, and thank you, Perry. It was really a great presentation, really great information, and I'm sure that's something that a lot of people will access on the recording on the PHN website. It's great to know that bigger picture and how sort of our Central Coast area fits into that bigger picture. So thank you so much. Thank you so much for listening tonight, and just to remind you to fill in the evaluation and give us some feedback if you've got anything. We've really enjoyed hosting this series on intellectual disability mental health, and we hope to be able to provide some more education on the coast in capacity building. So thank you so much, and we've got a 3-minute early mark, so good night.